Hi, everybody, and welcome to our module on pregnancy. First, let's talk about how we date the age of a pregnancy. There are two ways by which this is done. Sometimes people talk about the embryonic age. This is the age of the fetus dated to the time of fertilization, and this is often what's referred to in embryology textbooks when they talk about certain events occurring at 4 weeks or 8 weeks or 12 weeks. In clinical practice, however, we often use what's known as the gestational age. This is the age dated to the last menstrual period. A woman may not know when fertilization occurred, but she knows when her last menstrual period was before a pregnancy began, so that is an easier age to identify. And this is usually equal to the embryonic age plus 2 weeks, because women usually menstruate 2 weeks before their fertile period. The reason the fertile period is usually 2 weeks after the last menstrual period is because that's when ovulation occurs. And usually fertilization takes place within 1 day of ovulation for viable pregnancies. And you should be aware that fertilization usually occurs in the ampulla of the fallopian tube. If you look at this drawing on the screen here, this is the ovary, this is the fallopian tube, and this wide part here is the ampulla of the fallopian tube. And that's where the egg is usually fertilized, and then it travels down the fallopian tube to the uterus and implants in the wall of the uterus. Implantation usually occurs about 6 days after ovulation. This is variable, it may be 7 or 8 days, but around this time, the blastocyst implants in the wall of the uterus as shown in the picture here, and at this point in time, syncytial trophoblast tissue will begin secreting HCG, and that's important because HCG is used to detect pregnancies. So let's talk about HCG now. HCG stands for human chorionic gonadotropin, and the word chorionic is in the name to remind you that the chorion gives rise to the trophoblast tissue that secretes HCG during pregnancy. Now, HCG has a similar structure to luteinizing hormone. Both LH and HCG are two glycoprotein subunits. They are described in your textbooks as heterodimeric glycoproteins. The word dimeric means there are two subunits, and the word hetero means the two subunits are different. And then the word glycoprotein is there because they are glycoproteins. So both LH and HCG have alpha and beta subunits, and LH and HCG share the same alpha subunit. So it is the beta unit that distinguishes LH from HCG. And in addition, they both have the same alpha subunit as FSH and TSH. So you can imagine that sampling blood and testing for the alpha subunit of HCG wouldn't be very helpful because you can find that in lots of different hormones. But testing for the beta subunit of HCG is very useful because that is only found in HCG. Now, importantly, HCG can bind to LH receptors in the corpus luteum, and this is important because once pregnancy occurs, the HCG will bind to those LH receptors and maintain the corpus luteum. So why does HCG need to maintain the corpus luteum? Because the corpus luteum secretes progesterone, and you want that to continue when pregnancy occurs to prevent menstruation. If the corpus luteum went away, progesterone levels would plummet and the woman would menstruate and lose the pregnancy. So because HCG binds to those LH receptors in the corpus luteum, progesterone continues to be released by the corpus luteum, and this maintains pregnancy for the first 10 weeks, at which time the placenta can then begin synthesizing progesterone. So HCG can be used to detect pregnancy. Usually antibody-based tests are used. These are variants of the ELISA test that I discuss in the cell biology section. And all of these tests look for the beta subunit of HCG in the serum. As I said before, looking for the alpha subunit wouldn't be helpful because it's found in many other hormones as well. Serum tests are the most sensitive method for detecting HCG. They can detect very low levels down to 1 to 2 microunits per milliliter, and this test can be positive within 1 week of conception. Urine tests have a higher threshold. They cannot detect the pregnancy until the serum level gets up to about 20 to 50 microunits per liter, and therefore they may not be positive until 2 weeks or more. So this has important clinical implications. If a woman presents with abdominal pain or nausea that could be symptoms of an early pregnancy, and she says, I took a home pregnancy test and it was negative, those home pregnancy tests are usually over-the-counter urine tests, and they may have missed the pregnancy in an early stage, so you need to order a serum test to fully exclude that she could be pregnant. Let me briefly mention the syncytial trophoblast. This is a layer of the placenta that I talk about in detail in the video on the placenta. Shown on the screen are some chorionic villi, and the blue outer layer is the syncytial trophoblast. This layer of the placenta secretes HCG, as I mentioned before. It also begins secreting progesterone at about 10 weeks, and progesterone is required to maintain the pregnancy. So therefore, after 10 weeks, the placenta maintains the pregnancy going forward. The syncytia trophoblast also produces a hormone called human placental lactogen. It's also sometimes called chorionic somatomammotropin. This is a protein hormone, so it has a different structure from the steroid hormone progesterone, but just like progesterone, it is produced by the syncytia trophoblast of the placenta. And the levels of HPL go up as the placenta grows during pregnancy. And the key thing you want to know about this hormone for step 1 of your boards is that it blocks the effects of insulin. So it raises the blood glucose level in the maternal blood. This is good for the baby. It also promotes the breakdown of fatty acids by the mother for fuel, and it also promotes the breakdown of proteins for fuel. It basically creates a scenario in the mother where her blood glucose level is high and there are lots of fatty acids and amino acids available, and all of this is useful for the baby as it grows. So what this means is that women are vulnerable to the development of diabetes during pregnancy. Pregnancy is an insulin-resistant state. There is less response in the mother to the hormone insulin when she is pregnant. So women who have diabetes and become pregnant can see their glucose control worsen during pregnancy, and some women develop diabetes when they're pregnant. This is called gestational diabetes. So for these reasons, screening is often done among pregnant women for the presence of gestational diabetes. This is usually done with serum glucose testing, and it's high yield to remember this. Glycosuria, meaning glucose in the urine, is normal in pregnancy. I talk about this in the renal videos on the nephron, but there's less reabsorption of glucose by the proximal tubule normally during pregnancy. So screening women with a urine test is not helpful. You have to do serum testing, and that's how it's done among pregnant women to exclude gestational diabetes. So that's a nice segue into the physiologic changes that occur normally in pregnancy. We'll go through these in the next few slides. First of all, let's talk about plasma volume. So the total body volume expands in women when they become pregnant. This happens because blood fills the placenta, it's diverted away from the maternal circulation, and that is sensed by the body, and there's more renin released by the kidneys, and this leads to salt and water retention in the mother. When women are pregnant, the red cell mass expands. This is because there is increased maternal EPO secretion during pregnancy. If you do a blood test on a woman who is pregnant, however, she will appear to be mildly anemic. This is because there is a dilutional anemia that is normal in pregnancy. The rise in volume is greater than the rise in red cells, and as a result, there's a small decrease in hematocrit seen during pregnancy normally when women are pregnant. This is usually a mild anemia, and it's not severe enough to cause symptoms. Let's talk about the hemodynamics that occur during a normal pregnancy. The cardiac output rises. First of all, the preload goes up because of the rise in blood volume that we just discussed. In addition, the afterload is greatly reduced in pregnancy because of a fall in systemic vascular resistance. We'll talk about this in just a minute. And then finally, the maternal heart rate also rises slightly during pregnancy. So because of all these reasons, the cardiac output goes up when a woman becomes pregnant. Peripheral vascular resistance falls among women who are pregnant. This happens first of all because the placenta is a low resistance system placed in parallel with the rest of the body. I'll talk more about that in a second. In addition, there is some maternal vasodilation normally in pregnancy. So for this reason, blood pressure normally falls among women who are pregnant. They tend to have lower than normal blood pressures. Now, in the cardiology section in the video on blood flow mechanics, I talk about how you can calculate the total resistance through a system with 2 different resistance vessels, and I talk about how there are different equations for calculating the total resistance depending on whether the 2 vessels are placed in parallel or in series. There's a very high yield tie-in with this blood flow mechanics when it comes to pregnancy. So I want you to imagine that a woman has a total resistance of blood flow through her body before she becomes pregnant of 10, so we'll make R1 10. Now let's imagine she becomes pregnant, and let's imagine that the placenta were placed in series with the rest of her body. And let's imagine that the placenta also has a resistance of 10. Well, this would obviously double the total resistance of blood flowing through her body to 20. But that's not the way it happens in the body. The placenta is placed in parallel, so it obeys these equations on the left side of the screen. So once again, let's imagine that the woman had a resistance of 10 before she became pregnant, and now we add the placenta during pregnancy with a resistance of 10. Well, if you do the math here, you'll find out that our total now becomes 5. So we've reduced the total resistance for this woman by placing the placenta in parallel. And that's what happens anytime you add a new conduit for blood flow in parallel, you lower total resistance. This should be easy to understand. Imagine if blood can only flow in one direction, that will generate a certain resistance. If you add a parallel option for blood to flow as well, the total resistance through the whole circuit will decrease. So by adding the placenta in parallel, you necessarily reduce the total resistance. In addition, the placenta is a low resistance system, so this further helps to lower peripheral resistance. And it's very high yield for you to understand how this occurs in pregnancy. This also means that after the placenta is removed after birth, the peripheral resistance for both the mother and the baby will rise because you've taken that parallel circuit away. And in the cardiology section in the videos on congenital heart disease, I talk about how removal of the placenta raises peripheral resistance in the baby after birth, and this is one of the factors that contributes to raising left atrial pressure and closing the foramen ovale after birth. Some women in the later stages of pregnancy experience what is known as supine hypotension. Supine means when lying flat. And in the later stages of pregnancy, when the baby's gotten large, if a woman lies flat, the baby can compress the inferior vena cava. This can decrease the venous return and preload to the left ventricle, and that can reduce the cardiac output. Now, the woman is lying flat, so it's not like she's going to pass out from low blood pressure. However, sometimes the body responds with a reflex tachycardia that can produce symptoms. So when women complain of palpitations when they lie flat in later stages of pregnancy, this is often the mechanism of that symptom. There are changes in the coagulation system that are normal during pregnancy. Pregnancy is a hypercoagulable state. This probably evolved to protect women against major blood loss at delivery. The levels of many clotting factors change during pregnancy. There's increased fibrinogen and decreased protein S, which is an anti-clotting factor. And through all these clotting factor level changes, women are more likely to form blood clots when they are pregnant. In addition, as I just described, the fetus can obstruct venous return, and this can create sluggish blood flow through the venous system. And for that reason, deep vein thromboses are common among women who are pregnant. And then finally, there are pulmonary changes that are normal during pregnancy. Ventilation increases. You can imagine that the woman has more carbon dioxide to exhale because of all the metabolism occurring in the baby. In addition, there are hormone-induced changes to ventilation. Mostly what changes is that women increase their tidal volume with pregnancy. The respiratory rate usually is minimally changed, and women usually are not tachypnic when they are pregnant. When labor begins, there are regular uterine contractions followed by progressive dilation of the cervix and then eventually descent and expulsion of the fetus. This normally occurs at about 40 weeks, and preterm labor is defined as labor that occurs before 37 weeks. If a woman develops uterine contractions before the baby is thought to be ready for delivery, you can try to inhibit those contractions with two drugs, terbutaline and rhydodrin. Both of these drugs are beta agonists, so they raise the level of cyclic AMP inside of the uterine smooth muscle cells, and this leads to relaxation and an inhibition of uterine contractions. The APGAR score is used to assess newborn babies immediately after they are born. This is a 10-point score that's calculated for a newborn baby in the delivery room, usually at 1 and 5 minutes after birth. The way you calculate the 10-point score is by assigning a value of 0, 1, or 2 for 5 categories. The first 2 categories are heart rate and respiratory effort, followed by muscle tone, followed by how irritable the baby is, and followed by skin color, whether it is pink or blue. And if the 1-minute score is low, the baby is then reassessed at the 5-minute point looking for improvement. If the 5-minute score remains less than or equal to 3, this is associated with permanent neurologic damage, as is seen in cerebral palsy. This usually indicates some sort of major central nervous system dysfunction. Women sometimes elect to terminate a pregnancy. This is usually done in the earlier stages of pregnancy. This can be done surgically, but there are also 2 drugs which can be administered to cause pregnancy termination. The 2 drugs are mifepristone and misoprostol. Mifepristone is an anti-progesterone, so it blocks progesterone effects on the uterus. This will prevent implantation and cause the woman to shed her uterine lining. Remember that when progesterone levels fall as a normal part of the menstrual cycle, the woman sheds her uterine lining. So if you block the effects of progesterone on the uterus, it will not prepare for pregnancy and the lining will be lost. Misoprostol is a synthetic prostaglandin E1 analog. This induces uterine contractions. And if you use these 2 drugs together, medical abortion occurs in greater than 90% of women. Now, just a side note here, these 2 drugs are not used in ectopic pregnancy, and don't get this wrong on a board question. In ectopic pregnancy, the pregnancy occurs outside of the uterus, so these 2 drugs which target the uterus are not helpful. Instead, in ectopic pregnancy, methotrexate is used, and I talk about ectopic pregnancy in another video. And that concludes our module on pregnancy.